Good afternoon, everyone. Welcome to another Canadian Epilepsy Teaching Network educational rounds. Today, I have the pleasure of introducing Dr. Julia Jacobs, who's going to be speaking about high-frequency oscillations, clinical relevance, and new discoveries. Dr. Jacobs is the director of the Pediatric Epilepsy Program at the Alberta Children's Hospital, and she's a professor affiliated with the Department of Pediatrics and Clinical Neuroscience at the University of Calgary and adjunct professor at the University of Freiburg, Germany. Since 2022, she also serves as the Assistant Dean for Postdoctoral Research at the Cummings School of Medicine. She was born in Germany and trained in pediatric neurology before coming to Canada for the first time as a fellow at the Montreal Neurological Institute. After completing her fellowship, she moved back to Germany for 10 years, where she most recently worked as the director of the Department of Pediatric Neurology in Freiburg, and then moved back to Calgary in October of 2019. She is a clinician scientist aiming to bring new diagnostic tools and treatments to children with rare and difficult to treat epilepsies. Her most recent work focuses on helping to understand the individual risk of patients to develop seizures and treatment strategies that might help prevent severe epilepsy in children. This includes developing new diagnostic tools and biomarkers using intracranial EEG. Her research has been awarded with several international awards, including the Epilepsy Award of the American Epilepsy Society. In 2022, she became a fellow of the American Epilepsy Society, and she has served on numerous scientific committees within the American, Canadian, and German Epilepsy Societies, and is a member of the Pediatric Medical Treatment Task Force of the International League Against Epilepsy. She also serves as an associate editor for Epilepsia in the Journal of Clinical Neurophysiology. So without further ado, thank you so much, Dr. Jacobs, for joining us today to share your research and expertise on HFOs. Really looking forward to your talk.
Thank you very much for inviting me. I think what I did in this talk is try to find a good middle ground between, on the one hand, giving those of you who have never heard about high-frequency oscillations or have heard very little about it, a bit of an introduction, but also talking really about what I think are the exciting news in the fields and clinical relevance. So our learning objectives for today is to understand the current evidence that high-frequency oscillations are an important biomarker in epilepsy, learn how HFOs can tailor treatment in epilepsy, and understand some practical aspects on what we have to do to analyze HFOs and pitfalls to avoid. As a very short introduction, you are all aware of the classical frequency bands we look at in the EEG, and the high frequency oscillation spectrum just pushes above that between 80 and 1000 hertz. Traditionally, we have separated ripples from fast ripples, but in my talk, I will most likely speak the majority of time about HFOs in general, because we know by now that there's not such a strong separation between the ripple and the fast ripple band, at least when it comes to clinical relevance. We've learned a lot about interactions with epileptic spikes, changes in sleep, and occurrence and predominance in different brain regions, and this is what I'm going to talk a bit about. What is important for you is that we know by now that we can record them in almost every setting. So this is from the original research where you see a macro, micro electrode combined, but we also know that we can see them on the scalp EEG, we can see them on the MEG, so they are really widely used at this point. Our last workshop about high-frequency oscillations was in 2024 in New York, and we had a lot of discussions about what is an HFO and how can we see an HFO, and I think that tells you a lot because we are 15 years into HFO research and we still have some of these basic questions. What we, I think, agree on is that most amplifiers can record HFOs if they have a sampling rate over 1000 hertz, that we should use FIR instead of IIR filters. You can find that in your EEG machine, and that we have to be very certain about which identification method we want to use. And this is from my group where we basically employed all kinds of different published HFO automatic detectors on different recordings from our center. And the main take-home messages from this is that there is a large number of established HFO detectors, and you will be able to use them freely, most of them freely, from the people who have developed it. But the most important is that they have to be trained and tested on your own data, because this is how they work best. There are specific features of some detectors, like looking at baseline activity, also recording spikes, doing spectrograms. So it really depends a bit on what you want to do with HFOs to choose your detector. And interestingly, while some were specifically designed for stereo or intraoperative EEG or scalp EEG, we did not really see a huge difference in their performance. So something that has been developed for stereo EEGs might still be working for scalp EEG if you adjust it appropriately. Now coming to the different types of clinical applications that we have looked at in the past for HFOs. And I think you can roughly summarize two options. We can use them for localization, and this is the classical pre-surgical context where we want to know which regions are responsible for generating seizures in my patient. And then the other option is we can use it to estimate the seizure propensity or disease severity in our patients. And I'm going to talk about both a bit in my talk today. Before I start with this, I want to tell you where I think HFO's place is in clinics. And for that, we have to talk about what's the current gold standard, following the saying that the gazelle doesn't have to be faster than the lion. It just can't be the slowest gazelle in the pack. So if our current gold standard is not great, maybe our a new gold standard doesn't have to be perfect as well. And what we know about the seizure onset zone, and I think you know these model here from Rosenau and Luder, is that the seizure onset zone is actually not always a great predictor of surgical outcome. And you can see this here in two studies where actually the seizure onset zone channels of seizure onset zone, when they were removed, did not predict post-surgical outcomes. So there's quite a lot of data out there. So we know that this biomarker, seizure onset zone, is actually not brilliant as a gold standard. The other gold standard, which we often use in EEG, are epileptic spikes. And we know that patients can become seizure-free despite multifocal and bilateral spikes. We know that actually removing a clear epileptic lesion is superior to removing spike localization when it comes to surgical outcome. But we also know that spikes can be useful sometimes, because if spikes are very widespread, this might be a red flag for poor surgical outcome. So in summary, epileptic spikes are actually helpful sometimes, but not perfect, showing the epileptic region. And if we talk about disease activity, I think this is a very pediatric view, because in pediatrics, spikes are much more frequent and much less specific. But I think all of you know that we have patients who have a lot of spikes and very little seizures. This might be true for healthy children that show Rolandic spikes, or also for siblings in genetic epilepsy who have spikes but no seizures. And what is important, because I think many of us have a different assumption in their daily life, there is actually quite good data showing that if you reduce anti-seizure medications in the monitoring unit, this is not associated with spike rates going up. And there's quite good data about this as well. So the spikes are actually not a good mirror for seizure medication wean. What else do we know about spikes and HFOs? We actually know that they are not completely independent of each other. This is from the very early work by Elena Arastaratho, and she defined 3 different occurrences of HFOs. They can be completely independent. They can be going with a spike, as you can see here, but not visible on the unfiltered EEG, or they can be riding on a spike, as you can see here. So there is a correlation between the two biomarkers, but they are not fixed link, and they can occur independently of each other. When we look at, is it better to look at epileptic spikes with or without HFOs? There have been quite big studies who try to understand which one is the best biomarker. What we know is if we look at the fast ripple range, they are very focal. They are linked to the seizure onset zone, but they lack sensitivity, so they will miss epileptic areas. And when we look at the overall portion of patients, actually looking at spikes plus HFO might be the best middle ground to find all of the epileptic areas at this point. In my group in Freiburg, we were very curious whether there is a difference between spikes that have HFOs and spikes that don't have HFOs in regard to their underlying generating mechanisms. And for this, we used hybrid electrodes with the microtips being able to record single and multi-unit activity. And what you can see here is that if you have an HFO that co-occurs with a spike that co-occurs with an HFO, you have an increase in the multi-unit activity, so the neuronal firing prior to that spike. This kind of increase we do not see in spikes that do not carry HFOs. So our conclusion was that there is probably two types of spikes and that they are not exactly the same. And this is coming back to the institute I trained in Montreal and to Theodore Rasmussen, who has had the idea for a long time that there might be different subgroups of spikes. He called them red spikes and green spikes. And of course, with my passion for HFOs, I would love to say that the red spikes, so the ones that are bad and showing epilepsy, are those which are co-occurring with HFOs, and the green ones are those which may be not as relevant for prognostication. And when we looking at both biomarkers, I think it helps us to find the most epileptic spikes. It might also help us to exclude physiological HFOs, and it definitely facilitates identification of both events. Let's move on to the two clinical relevant questions. And first of them is, what evidence do we have that removing high frequency oscillations is helpful to find epileptic areas and for surgical planning? And I just want to go back with you and discuss quickly what this means in regard to a hypothesis. Basically, if I say a biomarker needs to be removed or needs to be relevant for prognostication, then what I'm saying is I have to remove the areas that generate the biomarkers to become seizure-free. And if I don't do that, the patient is not seizure-free. That's our hypothesis. And then in epilepsy, we always have several levels of evidence. We can say, is a biomarker linked, for example, to the seizure onset zone? We can look at retrospective data. We can look at prospective data, and then we can do a randomized controlled trial, as you can see here on the bottom. What is clear in general is that the higher the evidence level, the less information we have in epilepsy, because it's much harder to do a trial like you see down here. Now let's see what have we done in HFOs. There have been some meta-analysis on group studies and retrospective. So we are pooling all the patients and retrospective studies and try to find out whether HFO removal is prognosticating surgical outcome. And as you can see here, this is relatively old data, but the evidence is there for fast ripples and ripples, but it's not very strong aside, from random evidence. So we should probably have been warned that when we move from retrospective to prospective prediction, we might sometimes fail. And this is something we did in our multi-center trial several years ago, where we said we pooled data from Freiburg, Montreal, and Los Angeles, and we wanted to say at the day when the SEG was running, can we predict how someone is going to do a year later in regard to his seizures? And for the group data, we could confirm that resecting HFO generating data areas correlates with a better post-surgical outcome. But for me as a clinician, it is much more relevant to say, can I predict outcome in my individual patient? And I brought you two examples here which show that this does not work. The first example is a patient or we can look down here at this one. This is the patient who had a seizure-free outcome, but you can see that the red areas with the HFOs clearly extend the area of the resection in green. So we concluded from this that in this patient, the prognostication was incorrect. And we were not the only ones who did this. The group in Zurich at the same time also did a prospective trial with a little bit of less patients. And what I pooled these two data sets together for you, and what you can see here is that we failed to predict the correct post-surgical outcome in 27% of our patients. And this also means that in 14 patients, if we would have tailored the resection according to the HFOs, we would have done a larger resection than necessary for seizure-free surgical outcome. And what is, of course, the issue with this bucket up here is that we have the complete removal, but the patients are not seizure-free. But this is a little bit in brackets because please remember, I can only look at stereo EG contacts that I have implanted, and I don't know what is happening in the rest of the brain. So we have an explanation why these might fail. We don't really have an explanation why these ones are failing. What have we done since then? Because that's data from 2018. We thought going bigger is better, and maybe we find better evidence. So this is an even larger multi-center study now, which included 146 patients. Between Europe and North America. But what you can see again here, the orange and the red are the failed no, they are the failed predictions. And again, we have evidence on the group data that there is a correlation between removing HFOs and seizure-free outcome, but we were not able to reliably do this in every patient. And because researchers are stubborn and we always try to prove our points, we went in another multi-center collaboration, this time with Harvard, and we looked at a bit of a different biomarker setting. So you can see here that we had a bit of a focus on spike ripples and spike gamma. And what we could show in this data is that the spike ripples were actually superior to the pure HFOs in predicting surgical outcome. But again, when you look at all the subjects and you see the higher the value here is, the more HFOs were resected. There was a pooling in the seizure-free group towards a higher resection rate, but we were again not at the point where we could predict individual outcome. What can be reasons for this challenge to predict an individual outcome? I think one of the things we have noticed by now is that HFOs are actually not as focal as we thought in the beginning, and there might be some propagation patterns and difficulties to separate propagation from the general, the actual focus of the HFO. So this is a study which then looked like if we only look at the focus of the HFO and we calculate some centrality values, so like where is the hub of the HFO generator, can we predict post-surgical outcome better than then? They only had 10 patients, but 80% of these were predicted correctly, and the area under the curve to predict outcome actually became better when we included the network information into the prediction. Even if we had this kind of conflicting data in the big multi-center studies, I think the group in Utrecht has been very courageous to say they want to do a randomized controlled trial to show whether HFOs are better than spikes in predicting the post-surgical outcome, and they used intraoperative ECOG to do this. What's important for you, so you can understand the results, is that this was a non-inferiority trial. So they did not try to prove that HFOs are better than spikes. They actually just wanted to show they are not worse than spikes. And unfortunately, they failed with this because, as you can see, 67% of the HFO guided group and 90% of the spike guided group were seizure free after surgery. And of course, this is pretty devastating when you get these results. So they wanted to understand what has happened, and this is the big challenge of randomized controlled trials in epilepsy. When they did a analysis about poor and good prognosis in their group, they could clearly see that in the HFO group, the um, poor prognosis was 36%, while in the spike group it was only 13%. So there was likely a challenge with how the patients were randomized, or like how they ended up being randomized. They, as a result of this, did some stratification by epilepsy type and epilepsy severity. And what they could show is that when they then looked at the extratemporal epilepsies, they were actually able to show that HFOs are performing same or better than spikes do. So not the results we wanted, but at least there is, again, some evidence that HFOs might be helpful. For me, there has always been the question, and of course, the spikes and the seizure onset zone have the same problem. How much are we influenced by the fact that our SLEG electrode cannot sample the whole brain? And could the scalp EEG maybe be helpful with that? And of course, additionally, when we have scalp HFOs, we have much more patients that can possibly profit from this. And we've done a couple of studies. The very first one of my group was to look at simultaneous intracranial and scalp EEG and actually prove that our scalp HFOs had an intracranial correlate. We also did a study where we showed that the more scalp contacts you have that show HFOs, the less likely it is that your patient will be seizure-free. And we also had some data that suggested that if you go from the normal 10-20 montage to higher density coverage, you probably will find more HFOs, which is not surprising because, of course, with our scalp EEG, we're largely undersampling the cortex. But now to the clinical use, we know we have scalp EEGs that we can use. Do we have clear evidence that they can be helpful to localize epileptic areas? And there is a very nice meta-analysis from Mike Zielmans, who looked at all the scalp EEG studies that were used for localization. And what you can see here is actually, I think, a reflection of the challenge of this kind of studies, because all the different colors here are the different comparison methods that people use to prove that HFOs have localization value. So some people looked at the epileptic hemisphere, some people looked at the region of interest in the intracranial EEG. So everyone used a different method, and that was largely the summary of this paper, that while there is value of scalp HFOs for localization, at the current point, the variability in methods is so large that it really is hard to come to a final clinical conclusion. So scalp HFO might help for surgical prediction, but they are far from perfect. After all that being said, I think personally, I am more excited to see what HFOs can tell us about disease severity in a patient. And, can we give a prognosis? And there have been different ideas about what HFOs could be used for to predict epileptogenesis, so who at risk will actually have seizures, to measure disease severity, how many seizures are we expecting and how poor is the prognosis, and the response to treatment. I'm not going to talk about seizure prediction today because that's a very difficult mathematical concept and would go way beyond the current talk. But as a clinician, I think in an ideal world, HFOs would tell us which patient will develop epilepsy, when we can wean medications, whether a treatment works or not. Basically, everything that we are asked by our families and patients all the time. And I'll show you a little bit what we know by now. So if we go to the very early stages of patients who are at risk of epilepsy, but we don't know yet when and why they will develop it, I think HFOs have very early in the animal models been shown to actually be predictive of whether an animal that had an acute initial insult will have epilepsy later on. So that is promising. And when we talk about epilepsy natural history, then we are talking about this part of the cohort here. So we have patients who are at risk of having epilepsy. You know, you have your classical tuberous sclerosis, or you have your early stroke, or you have HIE, or in the adult world, you have TBI, and you want to know who of these patients will have seizures. I think the strongest evidence we have right now, because this was a prospective trial, is data which I did together with my colleague in Germany, and we went for kids who had a first seizure, but no epilepsy diagnosis at the time when we saw them. And this is just a bit of a repetition for all of you. If we have first seizures in pediatrics, the likelihood to actually have epilepsy over a longer period of time is lower than 30%. And we're talking unprovoked seizures. So this is where we said, okay, 70% of our patients might have epilepsy in the long run, 30% likely won't have it. And we had EEGs in the first week after this first seizure and tried to predict what happens 1 year later. Does the patient have an epilepsy diagnosis or not? And this is the results of this trial. You can see here that the ripples were actually the most different between the epilepsy and the non-epilepsy group. The spike ripples were also significantly different. And what might be interesting to you, it was absolutely irrelevant, and I'm just talking about this cohort, whether the patient had spikes or not, to predict whether they had an epilepsy diagnosis 1 year later or not. And this is the area under the curve. So for saying ripples and spike ripples, how well were they able to predict outcome? And you can see it here. The spike ripples had a specificity of 83%, and the spikes were just performing much poorer because they had more sensitivity but less specificity. And of course, we can move on to this to other at-risk populations. We've done this by looking at neonates who had seizures and HIE to try to find out are HFOs correlated. What we know by now is that especially in the moderately abnormal background EEGs in the HIE classification, there is a predictive value for the HFOs on whether patients will have seizures. And there has also been data from the group in Switzerland that showed that neonates with seizures have significantly higher HFOs. For me, I think this was a milestone just because those of you who work with early EEGs know that we know very little about EEG ontogeny, and we didn't know whether these high frequency oscillations could occur in the neonates at all. And I think right now we have enough evidence that we have HFOs in this age group and that we might be able to use them in bigger predictive studies. Moving on to the patients who have already chronic epilepsy, and we want to know, or like an epilepsy diagnosis, and we want to know what is how severe is this epilepsy going to be? I put this graph out here because I wanted to show you that there has been a lot of studies already in different groups of diagnostics, in different EEG types, and all of them showed that there is some correlation between disease severity and HFO rates. What you can also see here that the overwhelming amount of data is actually from the pediatric space. And I think this is because pediatric EEGs are more active, and also the skull conductivity of children might make it easier to see HFOs on the scalp EEG. I just wanted to give you some examples where we actually have quite a bit of data. So in the select group of patients, so the benign self-limited epilepsies, we can clearly show that, I mean, all of you know that spikes are pretty difficult to use for prognostication because the majority of patients has a lot of spikes. So there has been this study here by the group from Maike Zielmans and us, where you can clearly see that this is the seizure ball here, and you can see the spikes were present no matter whether the patients had a lot of seizures or few seizures or no seizures at all, while the ripples, especially in the time domain, were very linked to those patients who were doing poorly and had very high seizures. This is data from Catherine's True group in Harvard, and I think what she could very nicely show is that if you have active select, you have high frequency oscillations, but if you become seizure-free, these actually drop substantially. And then going to the next step, not only saying how severe is an epilepsy, but we measure whether a treatment is successful or not. There have also been a couple of studies you can see here with different medications, from steroids to lacosamide, levetiracetam, mixed AEDs down here. And all of them showed that if you have successful medical treatment, your high frequency oscillations are going to go down. This is from a very early study in 2009, where we already showed this in intracranial EEG, and this has now been replicated by scalp EEG. What I find really exciting are studies like this one in children with IESS, where basically they could show early on that if the medication will be successful, HFO rates are going to go down, while if treatment is unsuccessful in this patient group, the HFO remains stable. And I think this could be a good prognostic biomarker in the future. Coming bit at the overlap, we of course often also want to know how severe is an epilepsy after surgery, and can I wean medication? Has my surgery been successful? And again, in this space, Dr. Ramantani from Zurich showed nicely that your post-surgical EEG should drop in HFO rates if the surgery was successful. Moving on to the last topic of my talk, are high-frequency oscillations specific for epilepsy, and what do we know about that? Are they all bad guys, as you can see down here? And I think you probably know that already. HFOs are not exclusive for epilepsy. We know for a very long time, and Buzaki was a leader in this field, that high-frequency oscillations, especially ripples, are occurring outside of epilepsy, and they are linked to memory consolidation processes. So there is the challenge to find the epileptic one and how to do this. And then I think the other question is, if I see an HFO in a patient's brain, can this only be representing epilepsy, or could it also be representing other disease processes? Why is this relevant for you when you want to use HFOs? The answer is quite easy. I think the physiological HFOs are a big part on why we fail to predict post-surgical outcome with HFOs in some of our patients. Because as you can see here, my current detector can only tell me all the regions that generate HFOs, but it cannot tell me whether these HFOs are physiological or pathological. So as long as we cannot give colors and separate the two, I might think that all of these areas need to be removed to be seizure-free. But of course, it's enough to remove the red and the yellow ones. And I think this comes very much down to what we have often in EEG when we talk about pattern recognition. And I've talked about the red and the green spikes earlier. Just because two things look alike doesn't mean that they are the same. And we need to learn how to be better in separating the biomarkers. When we're talking about HFOs, physiological versus epileptic ones, there are a couple of things which we have identified that might help. Looking at principal HFO characteristics, so things like amplitude, frequency content, and so on. Looking at the background activity around an HFO, looking at the brain region over which an HFO occurs, and also looking at co-occurrence with other events such as spikes or sleep spindles. I'm just going to give you some examples of what we know, because looking at all the aims to try to separate physiological and pathological HFOs might be a little bit too difficult. First of all, early data suggested, and this is from the group of Anatol Bragan and Rick Staba, that fast ripples are bad and ripples are good. And I think this might be true for microelectrode recordings of the hippocampus, but we have very strong data right now that in the rest of the populations with different EEG recordings and with neocortical recordings, this easy separation will not help us alone to find what's bad and what's good. We also have some data which suggests, and I think that's pretty nice, that that when you look at HFOs, it depends on whether they are stereotyped over one brain region or whether they have fluctuating features over that region. So when an HFO over one channel has always this, like different events have always the same frequency content, amplitude, or length, and they are very monomorphic, this is more likely to be an epileptic HFO than a physiological HFO. What we have tried as well is trying to get a better understanding about physiological HFOs in the human brain, how they look like, so that we can separate them from the epileptic one. And there is an intrinsic problem with this because we rarely implant healthy population, right? So it's always hard to say, do I really have a fully functioning non-epileptic area? And can I be sure that an HFO I look at is not epileptic but normal? So there has been some trials to do that. And one that we did is that we looked at areas which were determined functional areas doing electrical stimulation. So motor cortex, verbal language areas, memory areas, and then that clearly didn't have any spikes or any epileptic activity. And we used these HFOs and compared them to the HFOs in the seizure onset zone to find some separating characteristics. And as you can see here in green, we were able to build two subgroups, the physiological and the epileptic one. And Birgit Frauscher has actually published a really nice atlas where she showed where HFOs physiologically occur over the brain and to which rates are normal for certain brain regions. We moved on from that because, as I told you, I'm passionate about the scalp EEG, and I'm also passionate about looking at this in children. So we just finished looking at 244 healthy children to see how do physiological HFOs develop over age, and do we see difference in the different age regions and the different brain regions? And as you can see here, we actually found that HFOs are most frequent in these like in the earlier toddler years, as you can see here, and that they change in their frequency over brain regions. As you can see here, they are, for example, very frequent over the occipital region in the age range between 6 and 10, and relatively low in the older teenagers over the temporal lobe and the parietal lobe. So I think this is first data which might allow us to better understand how normal HFOs look then, and then hopefully compare them and enable us to separate physiological and epileptic HFOs better. To summarize all of the slides I've showed you in the last 5 minutes, we know a little bit how to get to separate the red from the green, but we don't have a perfect tool yet to do this in a clinical setting. But what you can take as a take-home message is that spikes with HFOs are generally probably more epileptic. Stereotypic HFOs are more epileptic. And then if we look about and the physiological ones, HFOs over functional areas are probably less likely epileptic. And we also have some evidence that if they are linked to certain physiological sleep features, such as the peak of the slow wave or the sleep spindle, they are also more likely to be physiological. And we are working very hardly on developing some future tools which will allow an automatic separation between physiological and epileptic HFOs. Last but not least, I wanted to show you a couple of slides about what we have learned about HFOs in the neurology space outside of epilepsy. So there is some data that suggests that in low-grade tumors and also in other epilepsy, in other inflammatory diseases, HFOs might not only be linked to epilepsy, but also signaling neuroinflammation. So this study here showed that HFOs were significantly more frequent whenever inflammatory components could be shown in low-grade tumors. And then there has been some really exciting data. This is from the animal model, but we at last American Epilepsy Association meeting, they also showed some human data that there is a link between high frequency oscillations and Alzheimer's dementia. And this is actually beyond just those Alzheimer patients who have epilepsy. It can also be seen in Alzheimer's without epilepsy. And I think that's just exciting to see that this biomarker might have value also for other neurological diseases. And with this, I would like to conclude my talk with giving you a couple of take-home messages and coming back to the 4 questions that we have discussed. So what is our current gold standard? I think we can agree that spikes and the seizure onset zone are used regularly, but they lack predictive value, and HFOs might be a valid add-on to that to be more specific. Like the spikes and the seizure onset zone are really sensitive usually, but they're not very specific. Can HFOs be helpful to find epileptic areas and help with surgical planning? I've shown you a lot of data, and I think the conclusion has to be that there is a correlation between removing HFOs and surgical outcome, but we are far from perfect, and we are especially not able at this point to predict in individual patients. And I think for me, the most difficult part of this is that I also cannot tell you in which patient I'm likely to fail. So we do not know why we cannot predict in some and we can predict in others. That's the same with the spikes and the seizure onset zone, of course. But I think when we want to come to a conclusion or help our patients, we need to know when a biomarker will be successful or won't be successful. Then what do HFOs tell us about disease severity? I think they tell us more in spikes, particularly in the pediatric space. And I actually think this might be the big future pocket to work on to say, can we use HFOs for all these areas of prognostication that we have questions about and where spikes fail. And that's certainly where my group is currently focusing on in their epilepsy research. And then last but not least, are HFOs specific for epilepsy? No, they are not. They occur in cognition, and they might be disease markers outside of epilepsy. I think this is a methodological problem that we have, but I also think it is a big it's a very interesting part for the future because, of course, we cannot only maybe use them to measure seizure severity in epilepsy, but we also might be able to better understand cognitive function in our epilepsy patients if we are able to separate the two subgroups. And last but not least, people always ask me, is that something that I can buy as a clinical toolbox and I can start tomorrow analyzing my patients? I think the funny part is that we have overcome all of the hardware problems. So probably everyone who's listening now has an EEG amplifier who can record HFOs. The big problem is really the processing and the interpretation of the data. And unfortunately, there's not one fits it all solution, but there's a lot of companies right now working on some simplified analysis methods. And I hope that we will end up with a toolbox that can be used by everyone in the future. And with this, none of the work I've shown you today is only my own work. We are a large team, and I've been very fortunate over the year to also work with a big international group of collaborators, which has been a lot of fun. And I want to thank all of them and, of course, my funders. And I thank you for your attention.
Thank you, Julia, for that really excellent overview. The information you presented is just so fascinating. I don't know if there's any questions yet in the chat, but can I ask you, in your clinical practice, I know you mentioned it's hard to use this on an individual basis, but are you using HFOs on routine EEG, for example, to help with clinical decisions or counseling patients yet?
I'm going to be honest, and I'm always being asked this question, and no, we don't. And I know there are two centers in Canada who use it as part of their pre-surgical evaluations, and I think this can be helpful. I think the big challenge is that it is not as easy to come, like, to get these analysis done in time. So you need a pathway, and ideally you need an engineer or someone with a very technical background to do these ad hoc analysis for you. And my biggest challenge has always been that I felt, I think this would be very important clinical information for me, but I don't want to do it if I cannot rely on it. So I'm not a person who applies a detector without double checking and says this is what's happening. And I think that has been the biggest challenge to say, do we have enough reliable enough identification and interpretation methods to actually use this for our patients? I could imagine that if we should, like, I think probably for me right now, the most exciting space is to say, in those children which are at risk, after neonatal stroke, for example, that's the population that we recently analyzed. And we know that spikes are not really helpful for predicting outcome in these kids. If we are currently trying to recruit prospectively for this, and if we would be able to show that we are better with the HFOs in this regard, then I think that would be one of the things where I think I would want to do it clinically all the time, because just I find that the current data I have is so insufficient to help the families that I think that would be a major breakthrough for me.
Yeah, no, that is amazing. Like, what a great biomarker this could be. Even TSC, right? With, how we treat spikes with vigabatrin before they develop spasms. It'd be very interesting to look at HFOs as well.